Welcome back. I would like to introduce our next speaker. It's a great honor to introduce Jordan Bohnen. Dr. Bohnen is an assistant professor of surgery and is a minimally invasive surgeon at Beth Israel Deaconess Medical Center in Boston. He's going to be talking about the role of anti-reflux surgery through minimal invasive techniques. Over to Dr. Bohnen.
Okay, thank you, Dr. Pranjape, and hi, everyone. Now that we've learned all about what endoscopic surgeons and endoscopists can do, we're going to talk again a little bit about traditional surgery, although the definition of surgery seems to be changing over time. So this is a talk on the contemporary surgical management of reflux, and I don't have any financial disclosures. This talk is intended to be a primer on the surgical management of GERD, with a focus on minimally invasive surgical techniques. It's geared for general medical audience, and I know many of you in the audience are not surgeons, but you may one day find yourself consulting a surgeon. And in this context, it's important to understand how surgeons think about the workup and management of patients with GERD. The outline is an introduction, and then various aspects of the surgical management of GERD, and then a brief summary. By way of introduction, GERD has many accepted definitions, including the commonly referenced Montreal definition, which describes GERD as a condition that develops when the reflux of stomach contents causes troublesome symptoms and/or complications. GERD is common and increasing, in particular in developed countries. And as in other specialties, surgeons distinguish between patients with typical versus atypical symptoms. We've heard about typical symptoms already, heartburn and regurgitation. And patients with typical symptoms tend to respond better to anti-reflux surgery than those without typical symptoms. Certain GERD-related complications also, including esophagitis, peptic stricture, Barrett's, or pneumonia, may also prompt a surgical referral. And with that said, many patients respond to diet and lifestyle modifications and/or PPIs and never require surgery, but surgery does remain a good long-term treatment option for many patients with GERD. To optimize surgical outcomes, a comprehensive workup and careful patient selection is necessary. So we'll talk a little bit about that now, starting with indications for surgery. If I could handpick one patient with the highest likelihood of undergoing a successful anti-reflux surgery, it would be a patient with typical symptoms who's PPI responsive. These patients have a high likelihood of symptomatic improvement following surgery, with success rates in the 85 to 90% range across several different studies, and good long-term outcomes and an acceptable risk profile. Herein lies the classic dilemma with GERD management, though, in that the best surgical candidates happen to be the ones that respond well to medical treatment. This means that surgery is generally not as effective for PPI non-responders, and that in PPI non-responders, it's worth investigating other potential etiologies and management strategies prior to considering surgery. The most common indication for anti-reflux surgery, however, is PPI responsive patients who have persistent symptoms. For example, after eliminating heartburn, patients still have persistent reflux despite maximal medical therapy. Surgeons have to be careful in working up these patients to ensure that their symptoms are actually due to reflux, as opposed to a non-reflux etiology like functional heartburn, or even something more sinister like a malignancy. Other patients who may benefit from surgery include PPI responsive patients who wish to avoid lifelong medication, patients with GERD-related complications, for example, esophagitis or stricture, and then truly refractory, PPI refractory patients with confirmed reflux-related heartburn. Approximately 2/3 of these patients in this group can actually anticipate improvements after anti-reflux surgery, which compares favorably with the improvements that we would see in these patients who don't undergo surgery. So on to the surgical management of GERD. We'll talk about the surgical phases of care, beginning with preoperative. There's also intraoperative and postoperative phases of care. So preoperatively, several questions should be answered before consenting a patient for anti-reflux surgery. Beginning with, is it truly GERD? Is this pathologic GERD? Secondly, does it respond to treatment, as we just discussed? And then thirdly, is something else going on here? This might include other surgical conditions, for example, achalasia or hiatal hernia, or non-surgical conditions, for example, hypersensitivity or functional heartburn. These might be suggested by the history and physical. Many of these questions inform the standard workup for all patients being considered for anti-reflux surgery. And this workup includes a barium swallow, an upper endoscopy, a pH study, and manometry. Starting with the barium swallow, it's often one of the first tests performed for patients with foregut conditions. A swallow study provides a roadmap for the clinical team, ruling in or out structural abnormalities such as achalasia or hiatal hernia or mass lesions. And also swallow studies can demonstrate reflux, but only a minority of patients with reflux typically have reflux-related findings on the swallow. An upper endoscopy is critical in the preoperative workup for a potential surgical patient as well. This can also identify structural abnormalities. And an EGD has the added benefit of allowing for biopsies to facilitate diagnosis, including Barrett's disease or even malignancy, which if discovered would potentially preclude anti-reflux surgery. And serial endoscopy can be used to assess treatment response. pH testing is considered the gold standard for confirming pathologic reflux, either using a catheter or with a wireless capsule. pH sensors take several measurements related to the number, timing, and duration of reflux episodes that ultimately help to identify pathologic reflux. And a Demeester score is a composite measure of the above variables with a score greater than 14.72 being pathologic. And then finally, esophageal manometry measures pressure at different levels of the esophagus. These measurements indicate the presence or absence of potentially a motility disorder that could explain the patient's symptoms. And manometry findings can help a surgeon tailor an operation. If a motility disorder such as achalasia is found, the management algorithm would change entirely. If a patient has evidence of ineffective motility or dysmotility, a surgeon might still proceed with anti-reflux surgery, but consider a partial fundoplication instead of a complete fundoplication, which we'll discuss shortly. All of the above previously mentioned information helps us to assess if a patient is an appropriate surgical candidate. The patient's health status and other comorbidities are also taken into account when we're assessing the risk-benefit balance in determining a patient's qualifications for anti-reflux surgery. So next we'll discuss the intraoperative surgical management of GERD, and we'll discuss a variety of minimally invasive procedure types for anti-reflux surgery. We'll also discuss surgical approaches and considerations for specific patient populations. The main goal of anti-reflux surgery is to create a physiologic equivalent to a normal lower esophageal sphincter in order to prevent pathologic reflux. And this is most commonly accomplished with a fundoplication or wrap of the gastric fundus around the intra-abdominal esophagus. Perhaps the best known and most common anti-reflux surgery is the Nissen fundoplication, named after Rudolf Nissen, who first described the procedure in the 1950s. This was initially performed open, but today laparoscopic Nissen fundoplication has become the standard of care for routine anti-reflux operations. The goal of this procedure is to construct a 360-degree wrap, as depicted in the picture on the right. In terms of the surgical technique, after we enter the abdomen, the hiatus is mobilized 360 degrees, and any hiatal hernia is reduced. The vagus nerves are preserved, and at least 2 to 3 centimeters of intra-abdominal esophagus should be mobilized and available, even if this requires more mobilization into the mediastinum. The posterior crura are suture repaired, and the gastric fundus is then passed behind the distal esophagus, and a 2 to 3 centimeter, what we call floppy wrap or loose wrap, is constructed over a 50 to 60 French bougie, typically with 3 sutures as seen in the bottom right image. A toupee fundoplication or a partial fundoplication results in a 270-degree posterior wrap as seen in this picture. Dissection is similar to a Nissen, but in this case with bilateral fixation of the fundus to the esophagus and crura. There are a variety of suturing techniques which essentially come down to surgeon preference, but it's important to note that the fundoplication should be seated along the distal esophagus rather than the proximal stomach, and the same holds true for a Nissen. As with a Nissen, toupee fundoplication is most commonly performed laparoscopically. And a door fundoplication is a 180-degree to 200-degree anterior wrap. This partial fundoplication involves anterior fixation of the gastric fundus to the esophagus and or crura, and suturing techniques again vary here. A talk on contemporary minimally invasive anti-reflux surgery would not be complete without making reference to the LINX device, which is also known as magnetic sphincter augmentation, or MSA. This is an FDA-approved magnetic device that is passed laparoscopically around the distal intra-abdominal esophagus and resides in a similar location to a fundoplication. LINX has two configurations: the closed position, which is depicted in the top panel image, which helps prevent opening of the lower esophageal sphincter and reflux, and the open position, depicted in the bottom panel image, which allows for passage of food, belching, and vomiting. Contraindications to this include a hiatal hernia greater than 3 centimeters, severe esophagitis, and certain metal allergies. One of the first key studies published on LINX appeared in the New England Journal of Medicine in 2013. They studied 100 patients and followed them for a year after the procedure. The primary outcome was improvement in esophageal acid exposure, and secondary outcomes included quality of life improvement and PPI reduction at 1 year. The authors found decreased acid exposure in 64% of patients, improved quality of life in 92% of patients, and decreased PPI use in 93% of patients. Longer-term studies are emerging with some favorable outcomes reported 5 years post-procedure and a reasonable safety profile. With these surgical options in mind, it's worth considering which might be the best option for a given patient undergoing anti-reflux surgery. Several meta-analyses and randomized controlled trials have compared outcomes for different types of fundoplications, but with mixed results, in large part due to the heterogeneity of the populations. Overall, laparoscopic anti-reflux operations result in high degrees of long-term patient satisfaction in the range of 90%, and similar reductions in esophageal acid and reflux symptoms regardless of the technique. Complete fundoplication tends to yield lower rates of prolonged PPI use, whereas partial fundoplication appears to cause less dysphagia and gas bloat syndrome. Posterior wraps may offer better heartburn control, while anterior wraps may be less likely to cause dysphagia as well. And ultimately, surgeon preference plays a large role in determining which procedure to undertake. Currently, there's insufficient evidence to recommend MSA or LINX over fundoplication, though initial data, as I mentioned, are promising, and many surgeons use LINX in carefully selected patients. A note on surgical approaches. When we think about surgical approaches, including or excluding endoscopic surgery, we typically think of open versus minimally invasive, and within minimally invasive, laparoscopic versus robotic. Minimally invasive anti-reflux surgery has replaced open surgery as the default approach, and laparoscopic anti-reflux surgery has similar safety and efficacy, but with a shorter hospital stay, faster recovery times, and reduced postoperative hernia risk compared to open surgery. Robotic surgery is increasing in prevalence, but still constitutes only about 25 to 30% or even less of anti-reflux cases, and remains more expensive than laparoscopic surgery with no truly demonstrated clinical benefit. The proliferation of new surgical robotic devices, either on the market already or launching soon, suggests that robotic anti-reflux surgery will gain further traction over the next several years. A few additional intraoperative considerations. For patients with obesity, in particular morbid obesity, who are considering anti-reflux surgery, they should be strongly considered for bariatric surgery, specifically a Roux-en-Y gastric bypass, which has excellent outcomes with respect to postoperative weight loss and resolution of GERD. A short esophagus occurs when less than 2 to 3 centimeters of intra-abdominal esophagus is mobilized despite best efforts, and the surgeon can perform a collis gastroplasty, shown here, where, this is depicted, at least the initial phase here, which is an esophageal lengthening procedure accomplished by taking a wedge out of the proximal stomach with a stapler to create a neoesophagus around which the fundoplication can be seated. In patients with Barrett's esophagus, anti-reflux surgery should be considered really only for management of symptoms, but not as a means to prevent progression to adenocarcinoma. And patients with dysplasia or malignancy associated with Barrett's should not undergo anti-reflux surgery, since additional procedures will likely be required. Current or persistent pathologic reflux after prior surgery is another challenging problem, and the approach to redo anti-reflux surgery, I believe, will be discussed in the next lecture. Just a moment on postoperative management. There are pathways that often facilitate standard clinical care. An example is shown at the top here with a patient staying NPO or allowed SIPs on the day of surgery with aggressive pain and nausea control. The diet is often advanced to clear liquids on post-op day 1, and patients are frequently discharged that day to complete a 7-day course of liquids at home. Enhanced recovery after surgery programs or protocols apply a multimodal strategy to accelerate patients in hospital and at home recovery. Some ERAS pathways are emerging for anti-reflux surgery and are primarily geared towards optimizing postoperative pain control and non-narcotic regimens. And some of the more common complications after anti-reflux surgery are listed here, including pain, gas bloat syndrome, dysphagia, and even surgical failure. But the vast majority of patients do well after anti-reflux surgery, and it remains a generally safe and effective operation in experienced hands. So to summarize, I just want to pose a quick question, a final note about the comparative effectiveness of surgery versus medical management. This is a topic that has been addressed and studied in numerous guidelines across the gastroenterology literature and the surgical literature. And the guidelines are based on a very large volume of literature. One recent analysis of 105 studies, including 62 randomized controlled trials, found that anti-reflux surgery was associated with superior short-term quality of life compared to PPI alone, but with really no difference in short-term symptom control. And longer-term comparisons offer mixed results. So surgeons and gastroenterologists generally agree that surgery is at least as effective as medical therapy in controlling GERD-related symptoms and can reasonably be offered to patients in the appropriate setting and after the appropriate workup. In summary, minimally invasive anti-reflux surgery is an effective treatment for GERD in appropriately selected patients. It's important to optimize patient selection by taking a thorough H&P prior to performing any surgery and by completing the workup. Laparoscopic fundoplication remains the standard with desirable outcomes achieved across different types of fundoplications. Surgeon preference and patient-related factors should be taken into account to tailor the appropriate operation to the patient. And finally, emerging technologies such as LINX and robotic surgery hold promise, but are not yet considered standard of care, and longer-term outcome studies are needed. With that, thank you very much, and I will be around for any questions after the next couple talks. Thank you.